of the MOS, who is going to enlighten us with different topics. So, over to you.
Thank you, sir. So I think the theme is fantastic, and that we'll be going over what is new in every specialty. So I'm going to be talking about orbit and oculoplastics, but before diving into what is actually new, I thought I'll go over a little brief of orbital fractures. So basically, the practical classification of orbital fractures, if you see, is when there is one is when there's an internal fracture, which basically means that the rim or the framework is intact, but only the walls are fractured. The other is where basically the impact is the cheek or the malar area, and as a result, you get an orbitozygomatic fracture where the orbit along with the zygoma is fractured. The third is where the impact is between the eyes or in the upper part of the face. As a result, the nose along with the orbit, and therefore it's called a naso-orbitoethmoidal fracture or NOE. And finally, a complex fracture where everything is involved. Now, to repair these fractures, we use implants. And in an ideal implant that we look for, whether it is titanium, metallic, bioresorbable, biointegrable, is that it should be stable. It should be easy to handle in terms of contouring. Biologically, it should not incite inflammation. And also it should be accessible in terms of cost and availability. So based on these implants, the currently that we have are bioresorbable, the ones on the left, that is Rapisorb, that is PLLG or Osteomesh. Bioresorbable means that the body will resorb them. Basically, they will facilitate bone growth over the implant and dissolve themselves and leaves behind only natural, normal, healthy bone. The titanium implants are obviously metallic implants. They immediately add structural stability and integrity. And the third is biointegrable implants, which do not dissolve or get resorbed, but they allow growth within them. Because of the pores inside them, they allow vascularization and biointegration. So these are, like I said, the bioresorbable implants, the titanium and the biointegrable implants. And then you also have mixed, which is a bit of both. You can have biointegrable along with titanium. And finally, you can even harvest bone from the body and put it in. Now, of course, you have a new kid on the block, which is PEEK, PEEK or polyether ether ketone. These are biocompatible and thermoplastic. So the reason I'm giving you a background is to show about what is new and how we applied the latest in orbital fracture repair in this patient. So this is a patient who was a 42-year-old male. He was on board a ship where he was working. There was a hydraulic pump explosion, and a metallic part came and hit his face. He had a primary fracture repair done elsewhere. And his complaints right now was that he had diminished vision in his eye. He had diplopia, enophthalmos, and esotropia. The esotropia was from a 5th and 6th nerve palsy, which is why the eye was inward because the abduction was limited. And cosmetically, he was concerned that it was not looking good. Now, if you look at his CT scans, we can see that in the coronal slices, the floor is completely fractured. If I can get a pointer. Yeah, so here, my cursor, you can see that the floor here is completely fractured. The medial wall over here is not present as it is seen on the other side. And the lateral wall here is deficient, and the floor is completely gone and shattered into multiple pieces here. So the lateral wall, the floor, and the medial wall of the orbit are all deficient. He had been operated earlier where only the zygoma was fixed. So clearly an ophthalmologist was not involved in the management of this patient because the zygoma and the maxilla have been reduced, but the medial wall, the lateral wall, and the floor defect have been left unaddressed. So what we did is went ahead, and if you see in these complex scenarios, we'll never be able to get a off-the-shelf implant that can fit in this unusual position. So what we do is a patient-specific implant. Now in a patient-specific implant, what is done is the CT scan images are taken. The normal side or the unaffected side is used as the template. So what we've done is, so this laser pointer doesn't work, it's too faint. All right, so the yellow that you see over here is the mirrored normal side over the unhealthy side. So using the mirrored side, if you were to see how different the abnormal side is, you can see how much there is a difference. So the medial orbital wall, which should be here, is actually over here. The lateral wall is, there is a defect over here, and what we see is the blue line that has been put is the actual implant, which if we place, we would be able to get the identical contour of the orbit in the normal side. So again, the mirrored side, the yellow is what should be the normal position, but you can see how the orbit is completely expanded because of the bony walls being defected. The same thing you can see even on a coronal slice here. So the normal orbit, the patient's orbit here is lying over here, this white line, but the normal contour should have been over here. And that is why we are now going to try to use this as the template to create an implant. You can see how big the orbit is, the volume is expanded. So the volume on the affected side is almost 32 cubic centimeters, whereas the normal side is 26. So based on the defects in the orbital wall, if you were to create this blue colored implant over here and then measure the orbital volume, you can see that we are able to match it. So this is what the biomedical engineer gave us, that this is the implant that you need to put. But this, you can see the size, the configuration, the shape is so absurd and unusual, it will never fit in, we'll never be able to surgically place it. So this is where we come in and help them design into a more easily placed implant. And these are two titanium implants that would snugly fit into each other there. So basically what they do is create a 3D skull of the patient, and then based on that imaging, they would then create these two titanium implants there. And using those, we went through a transconjunctival route, placed those two implants, and post-operative imaging, you can see that the floor and the medial wall have been addressed, as well as the defect on the lateral wall over here. And volumetrically, the patient is much better compared to what he was. So post-op imaging is important. A lot of surgeons shy away from that, but it is extremely important. You can see how we are able to address the bony defects and the orbital volume. The motility defect remained because of the lateral rectus palsy. He, however, refused squint surgery, so we put in a little Botox in the medial rectus, and this is his appearance at 6 weeks post-surgery. The enophthalmos, the motility, well, the motility is restricted, but at least the eyes are now central. The enophthalmos and the appearance, cosmesis in general, is far better than what it was. So to summarize, what is new, it is patient-specific implant. It is a breakthrough which is now very, very accessible and economical. It helps you customize secondary cases in an extremely unusual scenarios and give patients satisfactory outcomes. Thank you.
Thanks a lot, Akshay. Very fantastic and new things that we have learned. Very innovative and nice.